This conference will now be recorded.
Oh,
Oh,
wait.
who did
Oh,
that?
I'm sorry. I think I did it. I shouldn't have.
This conference will now be recorded.
It's Tuesday, June 11th, 2024. Welcome to the AnCan virtual support meeting for high-risk, recurrent, and advanced prostate cancer. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderators Len Sierra, John Antonucci, and Rick Davis, the founder of AnCan. Medical issues will make up most of our conversation tonight, but what you're hearing is peer support, not medical advice. We do not offer medical advice. Your treatment decisions should be made by your medical team. Funding for this meeting comes in part from companies that believe in our work and have provided sponsorships. We make it clear to them, and we'll make it clear to you, that our gratitude does not necessarily mean our endorsement. Our sponsors know that, and they help us out anyway. The companies are Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, and Blue Earth Diagnostics. Rick, did you want to lead off?
Well, all I would really like to do is welcome you back as a regular icon on the screen tonight. And we're delighted to have you step in and take over this Tuesday slot. And may it long be yours. Thank you for coming back.
Thanks, Rick.
And Ben's never really been gone, as some of you. I mean, he's been helping me. He's been helping all of the Brains Trust, but he's been listening to a lot of the groups on the recording. And knowing Ben, he'll still listen to these groups on the recording and listen to this one as well. But anyway, thanks for being here, Ben.
Thank you, Rick. So let's begin. We have some new participants tonight. Conversations with newcomers lead off our meetings. Jeffrey, you're the new guy tonight. Welcome. Appreciate you coming.
Thank
So
you.
your last name, Jeffrey, is
Nurse, like doctor.
and it's Geoffrey.
Correct.
You prefer to be called Jeffrey?
G.
G, got it. So I'll ask a few more questions, and the floor will be yours. Where do you live, G?
I'm in Denver, Colorado.
And you're how old?
59.
And did you say your prostate cancer was diagnosed just recently?
Yes, on the 6th.
Oh gosh. And what is your PSA?
PSA is 21. I'm stage 4, node positive. I did my PET scan and meeting tomorrow for my first meeting with the team about treatment options. So I'm very, very, very new to this.
So where are you being treated now?
Right now, my urologist is with a private group called Colorado Urology. My wife is in healthcare and travels around the country. So she has a lot of contacts. So we're going to potentially go to MD Anderson, Sloan Kettering, Dana-Farber, Siteman in St. Louis, and possibly go and get second, third opinions with all my paperwork to make sure that we're making clear-headed decisions.
That in itself is a clear-headed decision. So you have gotten a PSMA PET scan?
I did.
Have you gotten genetic testing?
Not yet. So that's top of my list for the BCRA 1 and 2 and for ARV7.
Yeah.
I'm fairly new at the research, so I may not be speaking exactly correctly, but yeah.
Yeah, the ARV7 is something that develops later on to guys who've been treated for a long time, typically, and it doesn't typically show up in a genetic test.
Okay.
But you're spot on about the others, and of course they'll tell you about ones you've never heard of. So one question we're always curious about is how you learned about these meetings.
Through a Facebook group,
Ah,
let's see, what's the name of the group? PCF Metastatic Prostate Cancer Support Group on
ah,
Facebook.
Prostate Cancer Foundation is a good group. Um, and we don't usually ask this, but how are you feeling right this moment in one or two words?
Confused,
Mm,
um, trepidatious,
yeah,
and
good
out of
word.
control. And
Yes,
out of control.
I hear that.
But I'm hopeful. I have amazingly strong family and friends. I have an outpouring of love from people. My son is staying with me for a little while,
Mm,
just in case I have a bad day. So I feel very
mm,
hopeful that I
mm.
that I have people.
That's so important. I'm glad to hear that. So it is, our questions are over. It's your turn to ask the questions. Is there anything in particular, anything specific you wanted to ask?
No, not yet. I feel like I'm still in information gathering and processing at this point, but I'm sure that as we talk about the go forward game plan, I'm going to have a ton of questions. Um, I'm one of those guys that wants to know everything about everything, which has
Mm.
been great for my career, but we'll see how it works out for cancer.
Well, you come to the right group because a lot of us are that same way. So, does anyone on the call have any questions for G?
I, this is Eric. I have a
Hi, Eric.
question. How you
Yeah.
doing? So, what did you, if you don't mind, answer the question is, what did the PET scan show the cancer, the prostate cancer was?
Yeah, so obviously the prostate was lit up
Mm-hmm.
like a lighthouse. I've got some in my pelvic bones and some of the other bones around the prostate. The
Mm-hmm.
lymph nodes around the prostate. There's a spot on my lung, um, and that's all we've ascertained so far. Again, tomorrow we're actually going to go through the images with the team and identify everything, but that was the initial feedback.
Okay. Well, what are the things that I first learned here, and the group can speak on if you can, is, I was seeing a urologist when I first got diagnosed, and you wonder, I forgot to get the oncologist uh, doctor to kind of be in charge of this.
Uh huh.
We
Well,
we
that
we we didn't we didn't pay Eric to say that, by the way. So um, God bless you, Eric. Yeah, I mean, one of the things I think that um, all of us moderators are thinking, and you already got the message, G, is that um, the person running the show for you will need to be a medical oncologist who specializes in genitourinary and preferably prostate genitourinary cancer.
Yep.
Um, and you don't have great choices in Denver. There's a couple of people. There's a couple of people at Anheuser
And
um,
shoot.
Anschutz. Thank you. There's a couple of people at Anschutz. There's a lady there. But if you're able to travel, then we can give you some really excellent names. It's really a question of where you want to travel. You can go to Chicago. You can go to Houston. Um,
Yeah.
I'm trying to think where the people I would want to see would be local to you, relatively local to you. So you have to sort of say to us, I'm not sure you necessarily need to go to all the different places. You don't have to go to Dana-Farber and Memorial Sloan Kettering. You could go to either or. I would suggest going to see it no more than a couple of the people that we suggest because we know they're really good. And most of the people in this room have seen the names that we give you. Um, the problem with just calling up and saying, I want to see a doc, is that they can assign you to somebody and they could be a junior person. Whereas if you go to names that we have um, suggested, then we know you're going to be going to somebody very reliable. It doesn't necessarily mean you'll have the chemistry with them. That's going to be for you to figure out. But they'll be really good docs. So, for example, and there are guys in this room who will say this. We know the docs at MD Anderson. Um, they our own preference right now in Houston is probably a doc who was at MD Anderson for 14 years and then just went next door to Houston Methodist to start her own GU practice. Is she better than some of those docs? I think you might like her better. I don't know that she's better, but we would suggest you going to see her at Houston Methodist rather than going to MD Anderson. But she's essentially an MD Anderson doc, but she just doesn't practice in there anymore. But if you really want to go to MD Anderson, then Jim Ward sees a doctor there. There's two or three good choices. So you have to give us some ideas. Um, and you ask for names. I think what I would ask you to do is if you list 3 places where you want names, we'll give you the best name in each place.
Fair enough. That's great. So my wife has actually compiled a list leveraging both urologists and oncologists across the country because she does work in the medical field,
Mm-hmm.
people out of MIMO and whatnot. So she has a list of about a dozen people that she's been referred to, and there's been 4 or 5 names that have popped up regularly. So I can definitely grab those and put
Yeah,
them in a
tell us what
chat.
those
Yeah,
tell us what those 4 names are right now, and we're happy. Maybe some of those names are people that the guys in this room are seeing. And the other thing is, some of the names she may have, they can be hard to get appointments with sometimes.
Absolutely.
So, tell me when you're ready. Now, whilst you're looking for that, one other thing, and we've got a couple of hands up, so I can't hog all the time, but we put I put for you the Promise clinical trial in the chat window. That is a free germline trial, um, which is conducted by Johns Hopkins and University of Washington in Seattle, UW, Fred Hutchinson. Um, it's the trial's actually run by Color. It's a Color trial, but it's totally free. If you click on that link, it'll open up in your browser, and they'll send you a kit, and you can do the genetic testing. That's just for genetic germline testing. The thing that your doctors will want to do or should want to do, certainly the doctors that we would send you, is that you also will need some somatic testing. My guess is right now you probably haven't had a biopsy, correct?
I actually have had a biopsy, came
Oh,
back +4, +5 across the board.
4 + 5. Okay, 4 + 5. So, you have tissue. You might be better off getting a liquid biopsy, sending in a liquid sample because it's also going to take in whatever's going on in the metastatic sites rather than just the tissue. That's going to be the call of your doc, but you will want to get some somatic testing as well as germline testing. And I think the germline testing is, even though the germline is going to show up in the somatic, which of the mutations you've made yourself, you won't know if they're inherited or if you made them yourself without doing a germline test. So I would suggest you get the germline test anyway, because your kids are going to want to know.
Absolutely.
So whilst you're looking for that list, I'll throw the floor over to Jeff Marchi.
Yeah, I just wanted to mention one thing. You probably want to get on ADT as soon as possible to stop your cancer from growing. It will drop your PSA to nothing probably and will stop the growth of your cancer and may shrink some of the metastasis. So you want to make sure you don't wait too long before doing that. But get yourself a good oncologist, GU oncologist, and they'll get you going on that.
Yeah, thank you very much for your feedback. That's near the top of our list. ADT, and then finding out if if the metastasation is still considered localized, so we can be whatever the word OLIGM whatever.
Oligometastatic.
Yeah,
Oligo. Like,
yeah. So those will definitely be the first questions we chat tomorrow about. Absolutely.
Um, we can tell you already that if you've got activity in the bone, it's not still local for sure.
And lung.
How many spots did they see on the scan?
From what we understand at this point, they saw 5 plus the lung, and the lung might be they said the lung might be an echo, but they don't know for sure.
Okay, well, again, you're sort of on the cusp, but because you're younger, I think a good I wouldn't be spending a lot of time with your urologist talking about treatment options. Let's just say that.
Okay.
And I wouldn't also put a lot of weight on what they tell you. That their options are to place you on a couple of hormone therapy drugs, an LHRH drug, and a androgen receptor signal inhibitor. So they're probably going to play down chemotherapy, but there are other docs who might consider you to be an immediate candidate for chemotherapy. So that's that. Okay, so we'll come to you, Jim, but Michael Morris, great. He's excellent. He's hard to get to. And we could suggest other docs who are equally as good at Memorial Sloan Kettering. If you're lucky, you might be able to get to him. We've got a couple of guys, but he's real hard to get an appointment with today. Thomas Flagg at Anschutz is not who I know. We know what's her name? Elizabeth starts with an S. Have frankly never heard of Thomas Flagg, but we can check him up. Who else have you got there? Any other names? Any
Well,
other
I'm sorry.
names, G?
My apologies. My wife is actually texting with me in another thread, sending me the information. She's not with me right now. So
Oh,
that's what we have so far.
okay. Well, look, here's what I'd suggest you do. Get with your wife, come up with 3 places where you'd like to go. And I really would suggest, and the group will talk to you about this in a moment, but I really wouldn't go to more than 3 doctors. I might only go to 2, as long as they were two of our doctors. Um, and we'll give you names in those places. I don't know Leslie Busby in Boulder. Is she a genitourinary medical oncologist? You're probably not sure.
Yeah, it's a he, and he's a medical oncologist and hematologist.
I don't believe he's a GU med onc. I don't
Okay.
believe, because we've got several people who are in the Denver area. I don't think we've got anybody on today, but it's not a name that we're familiar with. Similarly flagged, but Morris is a big name in the field. But just come up here. I'll put my RD at AnCan.org, and we'll give you 2 or 3 names, and we may, depending on who you choose, we may be able to give, to make an introduction for you.
I really appreciate it. Thank you. And I don't mean to take up everybody's time. I do appreciate the warm welcome and the great direction. So thank you so much.
No, it's a pleasure. And like I say, I would think about Chicago. I think about either Boston or New York. I think about Houston. If you want to go to the West Coast, we can help you there. Just let us know. We'll find. We'll guide you right. I'm Jim Marshall. Go ahead.
Yes, G, make sure that you get some kind of a testosterone test before you start on things um, to then establish a baseline. Okay,
Absolutely.
right? A testosterone test.
Absolutely.
That's it.
Makes perfect sense.
And Jim Marshall didn't ask the question I thought he was going to ask, which is, are you a veteran?
I already did under the covers. Answer.
Oh, okay. Okay. Okay.
What was the
And
answer, Jim?
I am not.
He is
okay.
not.
And
I was Flora.
and I see, and Dr. John has done a little research, and Busby is not the right kind of doc for you, sir.
Thank you much.
And don't worry about the time. We cut an extra big slice for newcomers. So you did not take up a lot of our time. I hope you. I look forward to your coming back next week.
Absolutely. I'd love to give you guys some updates on what they've told me and get some more direction from this group. Thank you so much.
I just want to
And
put in a couple of cents, Len, and then you're reminding us all, G, about our first few months after diagnosis and how panicky and scary it is. I was very shaky. I couldn't sleep. Had a lot of fear, and went to see my old psychoanalyst from the old days. I got put on some temporary sleeping medicine and an antidepressant. It really helped me a lot to get over the initial couple of weeks and months. So you will come to some degree of of not feeling acutely panicky anymore, like the rest of us here in the group, and it will happen. And anything you can do to hasten that adaptation, I encourage you to go ahead, especially if you can't sleep or something like that. They're probably going to be talking to you about, since you have cancer outside the prostate area, they're probably going to be talking to you about systemic therapies rather than local ones, just to give you a heads up about that. And please come back if you ever want to. We'd love to have you back.
Thank you, John.
Ben, did I cut you off? Did
Yeah,
you want
Ben,
me
I
to
wanted
I
to
continue?
cut.
ask if G has any history of prostate cancer or breast cancer or ovarian cancer in the family.
So yes, my father had prostate cancer, and he actually contracted melanoma on his nose from playing golf. So what he did was he had the prostate removed and then addressed the melanoma. He's 20 years post, plays golf every day, has no issues whatsoever. Nobody else in my family has a history.
Okay, good. Um, yeah, we don't give medical advice here, but I'm just going to tell you its probability is extremely high that no matter who you speak to, if they're a qualified GU medical oncologist, they'll probably want to put you on what we call triple therapy, which is the standard of care for someone with uh, your history.
Hmm.
So you might want to, bone up on triplet therapy while you're waiting to speak to the doc, so you'll know what they're talking about.
Yeah, I've already done some research, and I understand what that is, but I can definitely do a deep dive. One of the interesting things is that I have no symptoms, none whatsoever. I'm a fairly high-end athlete, so I'm incredibly healthy. So I'm hopeful that that helps me in terms of dealing with whatever changes are going to happen from the therapies. I'm hopeful that because I'm very hale and very healthy, that yeah, that I react well to this stuff.
Yeah, that will be helpful. To be honest, most of us probably have never experienced symptoms, and we usually don't until we're fairly well advanced. The only symptoms we have are from treatment, but it's necessary. That's it for me,
Wonderful.
Ben.
Yeah, good point on the triplet therapy. Okay, we will move on to our old hands. Um,
Can,
before
can I
I had a
just
little,
add?
yeah, yes, yes.
I just add one quick thing. So it's interesting, and I thank you for this. It turns out that Flag is a GU medical oncologist, although we'd never found him before, and I'm not sure they list him on their as in the GU area. But he's largely a bladder cancer guy. But what I would say to you is, sure, I mean, definitely he's local, and we'd love to find a good GU medical oncologist in Denver. So you may like him, and he may turn out to be the right guy for you.
Yeah,
So
I'll definitely meet up with him. My wife already has set up an appointment, and I'll let you guys know how I feel about him. We can,
yeah,
maybe, yeah.
we love we'd love that. I mean, the guy that let me just see if I can the woman that we know of who is fine, but we don't usually recommend her is I'm just pulling the website. I'm just pulling it up right now as we speak. Elizabeth. Let's see what her name is. Elizabeth Kessler, I think. Elizabeth Kessler is the woman. And it's interesting because when you look at the team, and they're all in the Flag Research Lab. Oh yeah, he is there. So yeah, go for it. That'd be great. Okay.
So, Daniel Straub, you've been waiting a week. What would you like to say? What's up?
I'm going to pass again because I just had a
Oh,
PSMA test today.
oh, I'm sorry. That's right. You said that.
Result. Right. I'm going to pass till next week. Sorry.
Yeah, I put a plus next to your name nonetheless. Okay. So, next up then is Steve. I guess Steve Lodge.
Yes, thank you. I started my Provenge treatment this week. They did the leukapheresis yesterday, and they're planning to do the infusion on Thursday. And is there much impact? People who have had experience, is there much impact from the infusion? I'm planning on doing some activities after and trying to figure out if that's reasonable or not.
Um, so who has anybody here done Provenge? Who has done Provenge in the group? If not, we can give you some feedback. Any Provenge people in the group right now today? Okay. So, a couple of little things. The first is that you want to be well hydrated, but that's more for the leukapheresis than it is for when they put it back in.
Yeah.
But you seem to come through the leukapheresis pretty well. We've had in the early days, but not so much recently. So when I say the early days, I'm talking about over 10 years ago. We used to see guys who would get a bit fluey. They'd feel like 1 degree under. They'd feel like they had the flu when they got at least with the first one, not so much with the second and the third. But it's not that common. So you could probably figure out to do something afterwards, but just be ready to cancel if you're not feeling great. Let me throw it to Ben or to Len or to Dr. John. Anything you want to add on Provenge, on the actual process?
I really don't know much about it because we've had so few people recently, and I've never had it.
Mm-hmm.
Yeah, Rick, the flu symptoms are very common, but when you consider other cancer therapies, if that's all you have to deal with is a little flu-like feeling for 24 hours, well ahead of the game. That's not a
Yep.
problem. I recall something about good idea to load up on calcium, I believe, or something.
Oh yeah.
Yeah, right?
Yeah. Where did that come from? Yes, somebody said that. Good one, Len.
Yeah, I forget the details. And they might give you some type of anti-allergy medication to help limit any reaction like the fever and chills you get from the fever, fever and chills that you get from the treatment.
Okay, well, thank you very
Well,
much, and I'll let everyone know how it goes.
you know, we're big fans. Not everybody is, and some of our favorite doctors are not, but we are big fans of Provenge. We have a very, very long history, and the innovator of Provenge, Larry Fong, is on our advisory board, and he's just a fantastic doc. It was the very first type of immunotherapy to be innovated for prostate cancer. And the common feeling now is that if you get it early on, like you are, so as to use Larry's terminology, you have a very long landing strip, then it works very well. We did a webinar with Larry several years ago. I'm going to look it up right now and put it in the chat window for you. I see you're on your phone, so hopefully you can get to the chat window. But
Okay.
I'll put it in the chat window, and it's probably worth watching Larry's presentation on Provenge. It was a very good presentation. We wish you lots of luck. And what we do know now, and Len probably remembers this better than I do, is that even though you don't see a real benefit in any of your markers, there's significant improvement in longevity, right, Len?
Yeah, that's particularly true if your PSA level is low at the time you start the therapy. What is your PSA, Steve?
Yeah, most recent was 0.2.
Oh, you're in a sweet spot. That's great. Yeah, it works best for people like you.
Yeah, I seem to be the ideal candidate for it. So,
Good.
Dr. Jeff, I'm sorry. Dr. Jeff, you wanted to weigh in?
I just have a quick question. Are they continuing your ADT or stopping
yeah,
it when you get it?
they're continuing it.
Thanks.
Okay, and I'm just putting the link in right now for the webinar. We did this webinar back in 2019. Oh my gosh! So, but it's really a good webinar. So it's worth a watch. And there it is. Okay.
What, Steve, what led you to choose Provenge?
It was as soon as my PSA became above the untestable level, it was recommended, and there potential for a major benefit and very few drawbacks from what I see.
Your doctor recommended this?
Yes.
Who's your doctor?
Um, Todd Yevzewski at Fred Hutch.
Good. Good luck with it. Okay, next is Peter Monaco.
Hi, how are you, Ben?
Hi, Peter.
So I just wanted to follow up from what I was talking about last week, just to refresh. I recently had a PSMA scan, which was generally pretty good. There was one spot near my clavicle, I was told, and my oncologist recommended I see a radiation oncologist, someone with Mount Sinai, my oncologist is also with Mount Sinai, Dr. Patel. So I went to have this consultation with this gentleman last week, and I didn't get the green light just yet. He has some concerns. He said the growth, the tumor, or whatever it is kind of close to the lung and the heart. Um, he says they could reach it, but he was concerned about the fact that I am on blood thinners, Eliquis in particular. I recently recovered from a pulmonary embolism, so he certainly doesn't want to play around with my blood thinners. But he said people who get this treatment that would be, like the one I would get, often bleed a little bit and cough up, spit up blood while they're going through it. It's the type of radiation that's the a series of 5 treatments given every other day. So it's pretty quick to go in and out through it to get through it. But he said he was going to get back to me, and I'm going to see him next week. But he actually wanted to confer with some of his colleagues and do some research on it. This is what he told me. So, anybody ever hear that? That kind of thing? I was all good to go. I was, I thought I had an opportunity to zap the one hotspot that showed up on PSMA scan, but now I may not be able to do it. I'm not sure yet.
Didn't Joel
That's my
Blanchett
update.
have a clavicle spot radiation? Anybody know? Is Joel with us? No.
No, not today.
Okay.
I mean, one of the things that I'm thinking, did he tell you what type of radiation he was planning on using? Was it IMRT or SBRT?
I'm pretty sure it's Rick, I don't want to say it's 5 treatments, and they last a few minutes each one, so it's not a long-term process. But I don't recall, Rick. I'm sorry. I should know that. I feel silly not knowing it. But I
Sounds
Um,
will
like
see. I see him again on the 25th of June. So maybe I should just report what he tells me at that point in time.
SBRT to me.
I think I heard that said, but that said, I don't want to report anything that I'm not 100% sure of.
yeah, but then, with spot radiation, they don't give a lot of sessions of IMRT either.
Well, when I went to, did you go to Richard Stock, Peter?
No, I went to his name is Dr. Stewart. Is that who you're referring to?
No, no.
Robert Stewart? He's
Well,
at their Union Square office in the city.
when I went to Stock at Mount Sinai for spot radiation consult, he was talking about using IMRT and like 20 sessions. I walked
Wow.
out of that office pretty quickly.
Oh no, he's not talking about that. I know he said 5, and he said they're applied every other day.
Yeah.
I mean, it could be SBRT, but if it is SBRT, then it's worth having a discussion with him whether doing more sessions with a less strong form of radiation might be an alternative. I don't know. Ben, what do you think about that?
No, I don't know. It's an interesting idea.
That would make sense. I mean, his concern was my bleeding. He said some patients do bleed a little bit. They'll cough up blood, and he knew about my history with the PE and being on Eliquis, and he was like, I got to check out your situation before I approve going ahead with it. That's that's where I left off with him.
Did you get the impression
Anybody?
that uh,
Go ahead, Ben.
did you get the impression that he meant that only this area led to bleeding, or that radiation in general, some people bleed?
Uh, the area where it was going is very close to the lung and even the heart, and he was concerned about bleeding. That was his major concern with it. So it turned into like a risk versus reward type of conversation because, I mean, I asked him, and this surprised me. I said, well, to what extent does the radiation eradicate the spot? And he said, you never can tell. That was his response. I was like, what? And he said, sometimes it kills it completely and sometimes it doesn't. And I was like, well, that sucks, especially if I'm risking bleeding out, maybe it's not a good equation. So
It's certainly to his
that's where I'm
credit that
at.
it's he's a good doctor, have read your chart and been alert to this serious potential complication.
Yeah, I mean, I thought it was good that he said, let me take a back step here. I want to do some research. I want to speak to some of my colleagues, and let's meet again in a couple of weeks, and I'll let you know what's the best way to go. So I'll know that next week.
Dr. Jeff, did you want to weigh in?
Did I hear it right that this is a lymph node that you have by your clavicle?
Yes, that is correct.
And do you know, is the node above the clavicle or below the clavicle?
I don't know that, Dr. Jeff. I don't know the exact location.
Okay. Because even if you have a lymph node below the clavicle, that's not that close to your heart. It's anatomically, it's close to your lung, but it's not that close to your heart. So uh, I'm I'm a little confused why he's telling you it's too close to your heart. I would think that the thing he's most concerned about is pulmonary bleeding, not bleeding into your heart or from your heart. That doesn't seem logical to me.
Well, he mentioned that as soon as he knew that I had that PE, he was like, all right, we got to do some research about this because this could not be a good thing for you to do, given that I'm on blood thinners.
And which lung did you have the PE in?
It was in my right lung, upper,
Okay,
and I
so
was in the hospital
that
for 2 days, getting a heparin drip, and started to
that's a
resolve
good
it.
thing for you. If you had the PE in your right lung and your node is by your left lung, at least they wouldn't be radiating where you had the clot.
That's that's a good point. I'm sure he's aware of where exactly it was. He had my records from the event that I had in my hospitalization because they're all on Atlantic Health System. So I've got everything out there. So, uh,
Well, Peter, if you're unhappy with them not going ahead with it and you want a second opinion, you can go to Michael Zalewski at NYU. He's
okay.
excellent. Yeah.
Great
Yeah,
suggestion.
um, I'm reading from the PSMA test lymph node zero point 0.4 by zero point 0.3 cm right lower paratracheal lymph node with intense tracer uptake, SUV max 47, otherwise no radio tracer, avid, um, lymphopathy or something. I can't even pronounce that. So that's where it is.
That's a
Is it even
different
on the
ballgame
same side
than
of your
your
chest as the
clavicle.
heart?
Say again. Somebody, I hear some noise in the background. I'm losing you.
It sounded like it was in the right side of your chest, not the left side.
Okay, yeah.
I don't think,
What's this right lower paratracheal lymph node with
yeah,
intense tracer uptake.
yeah, Jeff is right. Your heart is not involved. It must be the lungs that there's a concern about. I mean, radiation causes scarring, but before the scarring, there's got to be some acute inflammation, right? Which could bleed, I suppose.
And that could cause bleeding.
Well, I
And
don't know.
paratracheal nodes, though, are close to your heart. The
You said they were
paratracheal,
close to the heart and close. Is that also close to the lung
yes,
or
yeah,
in the lung? Is it in
both.
the
It's
lung?
close. No, it's not in, but it's near, kind of above and to the side. But
Right.
that's different than clavicle. Your trachea and your clavicle, two different places.
I guess when they say clavicle area, that's what they're talking about.
Must be way up in the trachea.
So he said, radiation in the area near your heart or lung. And he said people who get radiation in that area often will spit up some blood. And that was his red flag for me because of the PE and the Eliquis.
Yep.
We're repeating.
So I don't know. I may not be a candidate. I'll find out next week. But
How
maybe
long
I'll
are
go
you
see
going to be
somebody else.
anticoagulated?
I
Six
mean, go
months or
off it?
something? Yeah,
Well,
like
I mean,
six
I've
months
had
or
surgery
something?
in the past, hip surgery, where I went off it for 3, 4 days. You can't be on blood thinners when you have major surgery. So I don't know. Maybe that is something they can do.
How long have you been on the Eliquis?
Oh, I had a PE, and this was my second PE, unfortunately. First one was in 2018, so I've been on it. Does that make it 6 years? Um, Recently, I switched from Eliquis to Xarelto for cost reasons, and they believe I was on the wrong dose of Xarelto. I was on a maintenance dose. I should have been on a treatment dose, and I got another one. So uh, when I went to the hospital and they cleared everything up, they said you've got to be on Eliquis on a 5 milligram twice a day regimen, not less than that. So that's my situation with that. Fortunately, my insurance company now does cover Eliquis, so I did the whole thing for no reason at all. Pretty stupid. But I was on 10 milligrams of Xarelto, and they said that wasn't quite enough. I should have been on twice that amount.
Last question from me. Are you throwing these clots from your legs?
Yes, I have DVTs in both legs. So
And
I'm
have
going to
the
see a vascular doctor in a couple of weeks. That was a recommendation when I was discharged from the hospital because they did that Doppler ultrasound and they said, yeah, you've got them in both legs. You got to see a vascular surgeon. Maybe there's another solution for you.
sometimes they put in filters. I'm sure you
Right,
hear about that,
right. And I'm interested in that. If I can get off the blood thinners, I'd be very happy.
right?
Yeah. But it's hereditary. My mother had this same thing, I guess. So, well, that's all I got, fellas. I'll report when I do see Dr. Stewart and what he recommends. Hopefully, he'll say he figured out a way to do it because I would prefer to do it if I could. Any shot I can get to, you know, zap the one thing I've got going out there, I'd like to do it.
Thank you, Doctors Jeff and John. It's wonderful. Your depth of knowledge as from your training is so useful.
Yes, definitely. Thank you both. I appreciate your feedback.
That brings us to you, Eric. What's up?
Not too much. Just want to update. So I get my first Lupron shot tomorrow.
Aha.
So I'm going to. Um,
Congratulations.
yeah. The the other thing that I was waving. So like with this medical insurance stuff, and not to go too deep, it is kind of crazy. So my company is switching medical providers. Going back to my old provider, going back to Cigna in the beginning of July. Um, Cigna approved for me to have Orgovyx, but
Ooh.
my current insurance didn't. So this is why I'm going with Lupron. So now I'm in the puzzle of like, do I wait, 14 more days and try to get Orgovyx, or just go with the Lupron?
If it were me, Mr. W, I would wait. If it were me.
Okay.
Because they're probably going to give you a 90-day shot. And if you can get the Orgovyx, it's such a better drug. We just keep hearing about it time and time again. Works better. That if you can get it. I mean, have you started the enzalutamide yet?
No. So I got the enzalutamide actually this weekend, but I sent a note to my doctor through my portal, when she wanted me to start taking it, because I didn't know if I take it for Lupron, after Lupron. I didn't know, so
Yeah.
she hasn't replied yet. But I have an
Okay.
appointment tomorrow.
So we are aware of people that have done monotherapy enzalutamide, meaning they've just done the enzalutamide and they haven't even done the LHRH. So you might want to ask her, is it okay to start the enzalutamide and rather than getting the Lupron shot, can we try and get Orgovyx because my new insurer was my old insurer and they approved it and see where you
Right.
go. And we can't give you medical advice, but well, I can't, but maybe Dr. John can wade in here or Dr. Jack or Dr. Jeff. But if you're on enzalutamide for the next couple of weeks without the LHRH, it's probably not going to make a heck of a lot of difference. So that's my 2 cents.
Dr. John,
Dr.
Dr. Jeff.
John.
I'm actually more confused than enlightened. Do I have my Erics mixed up, or were you considering a clinical trial somewhere?
So I was going to consider the clinical trial because I was having issues with my insurance. They initially denied me the medication. So uh, the trial was looking at one point like the best option that I had, but somehow through a broker my insurance worked with got me approved for the drug, and I got enzalutamide, and there
Okay, so
that's what that
the trial's out. We
the
don't have to worry
trials.
about that.
Yeah, the trial's out because the trial wasn't. It was a 50-50 chance or some kind of gamble of me getting the daralutamide and
Gotcha.
Lupron, you know, or a placebo and Lupron. So I just took the sure route instead of not knowing and taking it, going through this trial for 2 years and wind up not getting the standard of care that is required.
So
So
then the question that Rick was raising is there any problem starting with Enza while you're waiting around for either Lupron or Orgovyx? Is that the question?
well, the question is, I'm scheduled to get my first Lupron shot tomorrow, but
Oh,
I'm going back to
anyway.
Cigna, and Cigna approved Orgovyx, which my current insurance Aetna did not. So I'm thinking, like, should I wait until the 1st of July and try to get Orgovyx, or just go with the Lupron?
Well, I think Rick would wait. I think I probably would wait. I mean, you're on enzalutamide already.
I will be. At least I'll start. I mean, because she didn't tell me, because I just got the enzalutamide this past weekend. So,
Or you didn't take your first pill yet?
no, not yet.
Well,
And so that's going to be the discussion I have with Dr. Marshall tomorrow at John Hopkins. Is, here's the deal. Here's where we are. Um, you know, I mean, we already got to have the Lupron is already approved, but if we can have a chance to get Orgovyx, which I was on before, I know how my body at least reacts to Orgovyx. Uh, you know, little hot flashes once in a while. Nothing really too dramatic. But so that was the question I posed.
Eric, this is
Yes.
Dr. Jeff. You can ask for a 1 month shot of Lupron, so you'll have an overlap of 2 weeks. You don't have to get long acting. 7.5 milligrams is good for 1 month.
Okay.
So, if you don't want to upset the apple cart with the doctor, tell him, give me Lupron for a month. And when the month is up, I'm going to go on Orgovyx.
Okay.
Lupron takes a while to get active, and it takes a while to go away.
Yeah.
So I don't know that I would do something like that.
Okay. Okay.
Steve Rue, your hand was up briefly. Did you have something you wanted to say?
Well, I've had the pleasure of experiencing both Lupron and Orgovyx. Lupron initially for about a year, and the side effects for me were a whole lot more horrendous than the Orgovyx that I've been doing now. So I just wanted to throw that out there. But it sounds like Eric may already be aware of that, or has already heard that.
Yeah, I've heard that. I have heard that.
So if I was given a choice between the two, there's no doubt Orgovyx any day for me.
Okay.
Anyway.
Okay.
I suggest something. My experience is I started on darolutamide 2 months prior to starting the Orgovyx. So if you did the enzalutamide, it would be, I guess, comparable, because I felt very comfortable with it, because it really dropped my PSA essentially down to zero before I even started the Orgovyx. So, like Rick said, I think it's worth waiting for.
Okay. I will have that discussion tomorrow.
So is it the case that this is for the moderators and anyone else who happens to know? Is it the case that if you're taking Enza, you don't need anything to prevent the flare with Lupron?
No, if you were taking Enza, that would protect you against the flare.
Okay.
But I think that, Eric, haven't you been on didn't she put you on Casodex, bicalutamide before the Lupron anyway?
Yes.
Yeah.
Hmm.
Yeah. But Casodex, but enzalutamide is like Casodex on steroids anyway, so.
That's true.
Okay.
That's right. Yes. They do the
Right.
same.
So, but yeah. Jim Marshall, you got your hand up there.
Yeah, speaking about, anyway, the Casodex, a thought is to then continue it for a month, and then
Well, he doesn't need to Jim, he doesn't need to continue the Casodex if he's got enzalutamide.
well, absolutely, provided he does that. Provided he doesn't do that, then
Yeah, but he can.
there is
But that's
the
what.
alternative.
Right, but that's what we were saying from the outset, that maybe just do the enzalutamide and talk it out with Dr. Handy Marshall, and and figure it out. But I think you've got alternatives, and our experience, again, we can't give you the medical advice, but our experience has been that, just like what Dr. Jack said, the people that have been on monotherapy ARSIs have done pretty well. So, and we've had a lot of people on monotherapy ARSIs
Okay.
with enzalutamide, apalutamide, darolutamide, and abiraterone over the past several years.
Okay. Okay. I'm looking forward to having that discussion with her.
Thanks, Eric. So Len, here's that time you asked for.
Okay, thank you, Ben. I had a televisit with a radiation oncologist from MSK, the doc who first did my radiation back in 2016 when I had prostate radiated and the whole pelvic region. And he did a good job. At MSK at that time, I'm not sure if they're still doing it, they were giving 88 grays, which no one else in the country was doing. Everyone else was doing either 81 or even lower. So things went well for about 2 years, but then I developed radiation proctitis, and I had it mostly successfully treated with 2 rounds of argon plasma, which is a cauterization. Nevertheless, I am not anxious to have any further radiation that might damage my intestines or large colon. And so I let Dr. Boris Mueller at MSK know that that's my concern because I had a PSMA scan in October 2023, and there were 8 lesions that showed up, despite the fact that my PSA was only 0.2. So I went on darolutamide monotherapy, and my PSA has been at or near undetectable. 0.2 was the latest. 0.02 was the latest. But still, there was the issue of, well, what about spot radiation for at least some of the spots that I had? And so his recommendation, first of all, there was a T9 lesion, and he said, let's do an MRI of your entire spine, just to make sure there were no other vertebral lesions. And there weren't any. There's only the T9. It's fairly small, but it was there in October 2023, and it was there back in the first time I had a PSMA PET, which was July of 2016. So it's kind of persistent. So I really went to him to ask his opinion, what should be treated with spot radiation, if anything. So at first he said, well, could I treat these? Yes, that's certainly possible. But there's a left wall pelvic lymph node, which was the hottest SUV 25.6. And there was I always forget this one, a left lower para-aortic lymph node. That was 11.9 SUV. And I guess maybe I have to rely on Dr. Jeff to get his opinion on, is that likely to cause GI distress? Dr. Mueller said it could. So that concerns me. So question is, if I'm not going to do the 2 largest or hottest nodes, Because would it make any sense at all to do the other 6 lesions, 4 of which are bone lesions, which wouldn't cause any GI distress, but what's the point, you know? So I guess I just wanted to get anyone's opinion on that.
Well,
I know
size
it's,
isn't the only thing that matters, right, Len? It's the potential for future growth. I think that the size of a metastasis probably is a rough indication of the potential for future trouble. We don't have, of course, pathology in order to tell us which of all these mets are going to cause trouble in the future. So, I guess to me it sort of hinges on having nothing to go by but size. Do we make the conclusion that the 2 biggest ones are the only clinically important ones?
yeah, it's a good point.
But that's only a very rough indication of which is a clinically important one, isn't it? I don't know. I'd sort of like to say get rid of a bunch of them.
Yeah.
Harry?
I had 2 lesions on my spine that I had radiated, and one of them actually, since that time, it's it's got smaller. So it was pretty successful for me. Did you said you first saw them in October, and then you said recent MRI, and they haven't changed at all, or?
There was what they call an interval decrease. So between 2016, no, I'm sorry, between 2019 when I started darolutamide and 2023, there was an interval decrease in that T9. So it was smaller, but it was still there.
Okay.
Yeah.
Yeah, I always wondered if it was just the radiation or the radiation and the darolutamide I was on, both, caused it to reduce in size. It's hard to tell, I guess.
Yeah, it is. To my knowledge, there's no way to know what's responsible for the shrinking of the lesions.
Len, how do you differentiate a lesion that's been radiated that's now inactive from one that's still active cancer? If you've had radiation and darolutamide and shrinks down and it's still there. I just wonder, I asked that question to my radiation oncologist and he was very fuzzy about it. Sometimes he said you can't tell the difference and you don't know if the radiation really had an impact on killing it or whether or not it's still active. So I was just wondering if you guys knew more about that, because since my radiation, I've been kind of wondering about it.
Yeah, I should say that that T9 that was never radiated.
Oh, I'm sorry.
So in that case, that was definitely the darolutamide shrinking it.
Okay.
Yeah.
Okay. I wasn't sure. Thank you.
But he wanted to do another PSMA PET scan, even though my PSA is 0.02. And I said, well, yeah, Dr. O wanted to do that too, but he said, I don't think insurance will cover it. Dr. Mueller had a different opinion on that. He said, well, they should cover it because it's pretty clear that your PSA level isn't very concordant with what's going on with the scans, the PSMA scans, because when I had the PSMA scan, of my PSA was 0.2, and yet it picked up 8 lesions. So here we are 8 months later, after 8 months of darolutamide. He was just curious, like, what do these lesions look like now?
Len, that sort of confirms what I've said before, which is I don't think that the PSA level is that indicative when we already know that you have lesions. It's important when we don't know where the lesions are. And we need to get that PSA up to a certain level, whether it's 0.1, 0.15, 0.2 or higher, so that we can see something to begin with. But once we know there are lesions, those lesions are going to be, they're there, they're going to be active. And you know, they may make PSMA, but they may not make PSA. And so I think you should be listening to Boris and to Dr. O. And if they say no, then, you know, Dr. Muller, who's a really good guy and you like him, he's willing to go fight for you. And I bet Dr. O is willing to go fight for you too. So what's the downside of saying, yeah, I'll go for it and see what they say, and then let's see what's there. You know,
I agree with you.
um, the question that you raised, which is kind of important, is whether that para-aortic is likely to have an effect on your colon. And that's a question for Dr. Jeff or Dr. John or one of the other docs. Dr. Jeff, what's your thought on that lower para-aortic, the location?
Yeah, it's right below your bowel.
Hmm.
Yeah, so it could cause intestinal distress, right?
It's possible.
Yeah.
It is possible.
Now, on the one hand, you know, Mueller was saying, yeah, it could, but he also said spot radiation is not as likely to cause GI issues as, you know, full prostate radiation, full pelvic region radiation. So
Let me, you don't have to answer this if you don't
yeah,
want to, but if the insurance won't approve a PSMA PET scan, there is a place in Westchester. It's run by an MD, very dedicated guy, humanistic guy, and I think the PSMA PET scan there is under $2,000. I know when I had my PSMA PET scan, it was $13,000, and I had it down in Manhattan, and insurance covered most of it, but it would have been, if I had to pay out of pocket, it would have been very expensive. Out of pocket in this place. I can send you the name if you want, and you could actually talk to the guy. He's very approachable. And if you need it and you can't get covered, it won't bankrupt you.
yeah. Was it East River?
Nope, that's where I had mine, where it was 13,000.
Oh, well, this East River clinic where I went is in Westchester, though, White
Yeah,
Plains.
but they don't. So the East River on Westchester Avenue, they don't
Yeah.
do PSMA PET scans.
Okay.
I had to go down to 28th Street. I got my MRI there, but they do not do. They told me we don't do the PSMA PET scan, so I went to Manhattan to have it done. But this is in Hawthorne, the one I'm talking about.
Oh,
I'll share with you the name and the number, and if you want to go with it, you can.
yeah, please do, Jeff. Thank you.
Yeah, actually, share it with all of us for posterity, because this might be a resource for other people.
Say that again, Ben. We didn't hear you.
Yeah, I
Oh,
didn't hear you.
I'm sorry. I was suggesting that Dr. Jeff share it with everybody, because this sounds like it could be a resource for people down the road.
I'll do that right now.
Thank you.
Ben, whatever adjustment you just made, it made a big difference. Anyway,
I'm
that's
glad.
it for me. Thank you.
Okay, thank you, Len. Yeah, Ken Doyle. I know you're eager to speak with us. We're eager to hear from you. What's up?
You're on mute. You're still on
Can't.
mute.
Yeah.
You keep touching. There you
Okay.
go.
Ah,
All right. Okay. My picture went away. I didn't know what was going on. Okay. So 10 years ago, I got involved with AnCan, and 14 years ago, I had my prostate removed. And I got a tremendous amount of good advice. I appreciate that. So in 2018, I got an Axeman scan, which showed two hot spots that were about two millimeters in the prostate bed. And in 2023, I got a PSMA PET, and the notes in the report said they didn't find anything, and that the bladder was distended, so and would have had a tracer in it, even though I had been taken to the restroom to pee maybe a half hour before they did the scan. So the scan comes back that they don't see anything. Well, the good news is there's nothing to find throughout my body, but I figure the two hot spots are still there. And my first question is should and to part of the discussion you all were having about the cost of a PSMA scan. My PSMA scan was about $13,000. I only had to pay a little less than $2,000. Okay. Should I be expecting a redo from the scan organization, given that I still had urine in my bladder, and it's not because I don't get it all out. I had a urine expulsion test 2-3 weeks ago when I'm capable of emptying my bladder. And someone mentioned that they probably should have inserted a catheter. So I guess my first question is, should I expect a redo on that? If not, I guess I go back to my insurance company and push on them.
I'm sorry. Did you tell us what your PSA is
Say
currently?
again?
I'm sorry. Did you tell us what your PSA is currently? Did we miss that?
My PSA is about a 4 now. It was a slow rising
Hmm.
after the surgery, and I've looked at it every quarter, but recently it jumped about 1. So let's say it either went from a 3 to a 4 or a 4 to a 5.
So I guess the question I have is, do we know if you're PSMA avid? You may not be PSMA avid, meaning you may not make PSMA. There's somewhere between 10 and 20% of men who don't make PSMA. And
Oh, new information.
so, well, your doctors know that. For you, yes, of course, but your doctors know that. They should have told you that. So one of the things that you might want to do is get another Axumin scan, because that's always an alternative. It's not quite as accurate, but it certainly works. And we know that you responded to an Axumin scan in the past. We could say, well, do another PSMA scan, but if you don't make PSMA, then it's not going to show anything again. And it's difficult, as some of the guys on this call, I think one of whom is Dr. Jack, will attest. It's very difficult sometimes to tell, to get a test done to see if you make PSMA other than doing the scan that you did. On the other hand, there are people like Dr. Jack who did repetitive PSMA scans, and then finally he must have said the right prayer, because it did show something after we thought he was PSMA negative. So, Dr. Jack, you're a bit of an expert in this field. What have you got to say to Ken Doyle?
I'm no expert. Look, I just experienced a lot of scans going back to choline in 2017 and all the way up to 2 Axumins and 2 PSMAs and a CAT scan with iodine. So they were searching for so many years, for 5 years. You know, I'm 22 years out since my prostate surgery. So they finally found something. My PSA had to go, you know, slowly up to 1.5 or so before they found something with an Axumin scan and a subsequent PSMA scan. So
how high did you say it had to go?
No, actually, I think it was around 0.9. But I eventually, it went up to 2.2 before I started treatment, because it happened
I'm well
so rapidly.
beyond those numbers. Okay.
It was happening so rapidly, you know, suddenly from a very indolent, slow PSA that was rising over 5 years very slowly. The doubling rate took off and scared the hell out of me, so I got treated immediately after it. They found it in my subcarinal lymph nodes and a couple of bone spots. So, yeah, no expert.
So you were just doing watchful waiting until they could find it?
I guess you can call it that. I was being guided by a good, very good guy out in California, who I think is one of the better ones, and he was a urologist, but a very good one. And he helped guide me and not rush into treatment with hormones or radiation post-surgically.
So
he wanted to see where it was. Yeah.
What are the treatment options for an 80-year-old? I mean, if you're going to take the tests, you want to have a course of treatment in mind if you find something. And what options do 80-year-olds have?
Who are you talking to, me?
Anybody who knows the answer.
Well, this 80-year-old, I was 80.
Mm-hmm.
I was 84, and
Mm-hmm.
my treatment option was to go on doublet therapy, which I'd been on for a year, and not triplet, because I was oligometastatic and a bit old, and you know, a lot of wear and tear, and my white count went down, and on the doublet alone, and I've had a discussion about triplets, and we both concur it's not
Mm-hmm.
something to do right now, if ever.
So, you know, Ben, I think it's the same probably as for younger men, which is that if we saw something like with Len, we could talk about possible radiation, spot radiation. We could talk about doublet therapy. We could talk about monotherapy ARSI. You know, I think there are quite a few options. But it seems to me that a 4.0, with it creeping up, and it went up a whole point relatively recently, something's there. And if we're not seeing it with a PSMA-based scan, we've got to look in other ways. Ken Doyle, have they done any CT scans on you?
Yes.
And that
Total
showed
done.
nothing?
No,
And how recently was that, Ken?
that was probably 8, 9 years ago.
Okay, well, I'll
Nothing.
come back to you. Louise, I think if you're looking for the MS group, it's going to start in about 45 minutes. Okay, you're muted, but you can come back in 45 minutes. Okay, um, so they should be doing CT scans. Are you still with Fleming's practice in?
Yes, I am. Fleming is the one who ordered the PSMA, and it took me 4 years wrestling with Aetna to get them to approve it. And he never mentioned anything about PSA, about whether I was making PSMA.
Well, I go back to Fleming and say, look, let's do another Axumin scan. Let's do a CT scan. I mean, let's get our act together here, Dr. Fleming. He's got a high opinion of himself, Dr. Fleming. And sometimes I wonder, the other, we've got another guy who's treated by him in your area. And so, we could connect you to, but Ken, I really feel like you got to go in and you got to advocate with him and say, hey, doc, there's a bunch of things we can be doing here if there's nothing showing on the PSMA. And
Right.
say to him, what am I PSMA avid? He's going to say, well, I don't know. You say, well, if you don't know, why don't we do an Axumin scan then?
Okay.
You got to ask him the right questions so that you cross him up, because he should have been cut. I find it really amazing that these docs who consider themselves to be really top-notch GU medoncs and they don't see the obvious. We don't get paid for what we do, but geez.
After the scan was done, I didn't meet with him. I met with his nurse through a telephone call. So,
well, again, it's up to you to insist that you want to review it with him.
Right.
You have to do that. You're your own best advocate here, Ken. And now I got another question. Are you still exercising like you used to? Are you still crazy on that bike?
Here's where I think the problem comes from.
Yes.
With COVID, I got off the exercise routine. I have not gotten back on it. I'm pushing myself to try to get on it. I am running a business and highly active in my business, which requires a lot of physical activity.
Yeah.
But I'm not doing the 3-mile runs I was doing every other day in the 20-mile bicycle rides. And I've been suffering from some depression. So obviously, I think that's a contributor.
Well,
and the depression has taken away from me advocating for myself. That's why I'm here now.
Okay.
I got a new piece of information.
So now you're here. Now, one thing I can say to you, and I can't give you medical advice, and we've got 2 psychiatrists on this call, but if you start doing that exercise again, it's going to help you with that depression. I can guarantee that. I can guarantee. And you don't have to start with 3 miles and 3 miles a day and 20 miles. You can start with a mile, half a mile, a 5-mile bike ride. There's a whole bunch of things. I think I may have to hook you up with Rich Jackson, and the 2 of you can start exercising together. So, maybe that's what we got to do, because there's nothing like exercising with a buddy. And he's
and I live
in
a very rural area that doesn't have that feature, but maybe I need to push for it.
Well, look, you're in all right, wait a minute. Hold on a minute. I want to see how far you are from Jackson here, because How far are you from Norfolk?
I'm an hour and a half each way unless it's rush hour traffic, and then it turns into
Oh,
two.
okay. All right. Well, then
Yeah.
that is too far. Then we can't send you there. I don't know anybody close. I don't have anybody closer. Maybe I'll send Dr. John down on a special mission. uh, but no, really. I mean, Dr. John and Dr. Jack and Dr. Jeff, isn't that, don't you think it would be helpful if we could get Ken doing some exercise a little bit, and that's going to make it easier for him to advocate for himself with Dr. Fleming?
Certainly helps my mood.
Yep.
Yep, I'm in agreement.
Dr. Jeff, you already had your hand up briefly.
Yeah, I was just going to ask Rick, is a CAT scan better for him than an MRI to look at this, or it doesn't matter?
I frankly think the best thing's an Axumin scan. If it
Right.
were me, that's what I would be asking for,
Me too.
because and to combine that, and I can't answer whether the CAT scan is better than the MRI. That's a question I would ask one of you docs, because I'm not a great person when it comes to imaging. I just don't know. But I
Okay.
think that the Axumin combined with something else might be the way to go here. I don't know. Ben, you're pretty good on imaging stuff. What do you think?
And I would tend to agree, but not from a place of expertise. Just it seems what you say seems to make sense.
Would you go with an MRI or would you go with a CT along with the Axumin?
I don't know. Doctors have preferences, as you know, right? Some doctors strongly prefer one over the other.
How about FDG scan?
I'm not
Well,
familiar with that one. What is that? FTG?
well, an FDG PET is the CT. That's the Len, isn't that right? That's what they use for an FDG PET, which is based on glucose, isn't that right? You muted.
Yes, Rick, that is correct. But my understanding is that MRI is superior to CT scans.
Okay,
Yeah,
thank
it's
you.
more, more detail, thinner slices.
Thanks. There you go. Thank you.
MRIs are generally better for soft tissue, and CT scans are better for hard tissue, like bones and
Hmm.
stuff. And lung, well, viscera and all, MRIs are usually done.
Eric, you've got your hand up, man. Go ahead, go ahead. We can't, Eric, we can't hear you. But your microphone's on. Something's happened. I don't know what happened. Okay. I think we need to
So,
move on.
Yeah.
yeah, and so we can end this. I had one last question, which
Yeah.
is, it, my premise was, should I, at age 80, just forget about it and stop worrying about it? What I'm
Well,
hearing is there's some technology that probably needs to be looked at with the Axumin in whatever selected other scan goes with it, and go back to Fleming and engage with him. Plus, I really need to engage with myself in my physical activity.
yes, yes, and yes.
Okay. All right. Thank you.
Thanks, Ken. And thank you, Dr. Jack, for setting me straight on therapy. So,
I think we got.
um,
How did I do that?
oh, Eric, did you come back?
No, no, that was Dr. J.
Oh, okay.
I didn't understand how I set you straight on something. Did you really mean that, or were you?
Oh, yes. Yeah, totally. Totally.
What
Thank
did
you.
I? How did I set you straight? What did I do?
Um, that people get treated for real in their 80s, that they don't give
Oh,
you candy.
oh, oh, right. By the way, the thing I didn't add, in addition to doublet, I got SBRT at age 84. Right, right. A pretty strong dosage.
I frankly think that you make a great poster boy for Ken Doyle. That's what I think. We just got to get him, and we just got to get his head screwed on the right way, which I think we're going to do. Um, do we have, how many more people do we have, Ben, who would like time?
So Kurt Schaefer asked for time and Chuck Snyder asked for time.
Okay, let's go. We've got time for both of them.
Okay, mine is quick. Mine is quick. Um, I don't think I've reported in my last PSA testing at the end of April. I've been missing these sessions for a bit. So it's undetectable. My testosterone has risen all the way to 131. So that's great. And that's almost 15 times higher than it was. So that's great. Uh, Um, so lately I've been experiencing some breast tenderness. So I hadn't experienced any breast enlargement so much when I was on the ADT, but then after in a year and a half since I've been off of ADT, I've experienced some breast enlargement. So Antonanarchus said that that was common, or not common, not uncommon. When testosterone comes back in, there's a period of breast enlargement possibility that will then go away then when testosterone fully recovers. So I'm looking forward to that. But lately I've been aware of some tenderness in breast tissue that originally I was thinking it was because my personal trainer was abusing my shoulder workouts. But it's definitely I had a 2 week gap in my personal trainer and the tenderness persisted. And it seems to be more localizing to the sub nipple area. It used to be in the more halfway between nipple and shoulder, and now it's more underneath the nipple. So, but nipples aren't necessarily super tender. So, anyway, that's my report.
Now, you're not on any androgen blocker, right?
None whatsoever.
Okay. Well, it kind of makes sense to me. There's a lot more testosterone to turn into estradiol to stimulate the breast tissue. And the only thing I'm not knowledgeable at all about is what this means. And do you just wait it out and it goes away so that you become like before we ever got ADT?
That's my plan. And
That's the question. Yeah.
yeah, we'll check in again with Antonanarchus in a couple months and see where it's at then.
How different do you feel, Kurt, since your testosterone came
You know,
back
I
to the
never
normal?
I never felt very much loss of energy, and so I don't feel any much gain in energy, but it's still pretty low. So I don't know.
Hmm. What was your baseline testosterone before you started treatment?
About 400.
Okay, thanks.
So that's all I've got.
Thank you, Kurt.
Bye,
Bye, Dr.
guys.
Ken.
I gotta go.
Take care. Chuck Snyder, it is at last your turn. You have the floor.
Okay.
Hi guys, how you doing? So I just wanted to talk about my Pluvicto treatment. I went through four of the six treatments already, and I had really good response so far. The PSA, continued to go down with each treatment, and so after the fourth treatment, I got a PSMA PET scan, and my lymph nodes, where the cancer mostly is, in my lymph nodes in the prostate, the lymph nodes had shrunk to half the size, all of them. I guess there's multiple lymph nodes that are cancerous, but so I told my oncologist, I went through 10 rounds of chemo before this, and every 3 weeks got the chemo. I completed 10 rounds, and I was fine while I was on the chemo, but then all of a sudden my PSA started to skyrocket. So I told my oncologist, I don't want the same thing to happen with this Pluvicto. So is there any way we can maybe, um, postpone the treatment so I get more time out of it before I have to switch to something else? So he agreed to that would be a good idea. So I'm going to postpone this fifth treatment 6 weeks, and hopefully, get another PSMA, or another PSA blood test and see how I'm progressing. So, but right now I'm undetectable, which I'm very happy about. So I'm very lucky. I'm responding to the Pluvicto. So, but I just wanted to be sure. I asked him, is interrupting the treatment going to cause a problem? And he said, many of his patients have done that, and he didn't see any issue with doing it. So, but I just wanted to ask if anybody else has had similar experience with, stopping the treatment for a while, and just so that you can extend it a little bit. Um, so you're not using up the treatment quickly before you got to do something else. So that's my question. There may not be many people on Pluvicto here, but
I don't think that there's such a thing as using up the treatment, is there?
well, what I mean is, using it up every 6 weeks. 6 times 6 is 36 weeks, and before you know it, you're done, and then your PSA starts to go up, and then now what? So, well, I guess my thought is stretch it out a little longer.
There's no magic limit about 6, is there? If your blood indices are fine.
Yeah, I guess that's the standard of care, is every 6
Yes, it
weeks.
is. Yes.
But I guess that's my question: is it going to cause harm? Is it going to cause the cancer to start progressing rapidly if
Look,
uh,
here's the thing, Chuck. First of all, Chuck, I gotta say, you look great. You look a lot better than when you started, and I'm so pleased to see that. You got good color, man. You look. I hope you feel as good as you look. That's
Oh,
the
I
first
do.
thing.
Thank you. I haven't felt better. I ride my bike. Today I rode 15 miles. Saturday I rode 15 miles, and it's
Good.
just great being off that treatment. But
Well, we can see it. We can see it, and it's so good to see you that way.
thank you.
What we really don't have a lot of information on retreating with Pluvicto. We know it's feasible. We've had guys who have done it. We've had guys who have gone off. Al Latimer, who isn't here today, has been through at least two rounds of Pluvicto, each with I think the first one was 6. I can't remember how many he did the second time. Maybe 4 treatments, 5 treatments. I can't remember. But we just don't know. I mean, in a sense, we think that Pluvicto may be something like chemotherapy, where if you respond to it, you can give it again. and then you can give it again. But we don't have enough experience. So there's no reason to think that just because you've done 4 or 6 or whatever, and 6 is the standard of care, you can't do it again. How quickly can you do it? We don't really know. Most of the guys that we know that have tried it, and there aren't many, that's probably could count on one hand, have waited about 12 months before they've done it a second time. But like Dr. John says, if you're responding well, and if your blood count, if your numbers and your CBCs are good, you could keep on going. Now, would you? Probably not if you got down to undetectable. So again, we just don't know. Are you getting these? Are you still getting these through NYU? Is that where you're going for
Yes.
these?
Yes.
So I think Wise and David Wise, I know is your doc, but who's your nuclear doc there?
I don't remember her name. It's a woman.
It's a woman, isn't it? Yeah, I vaguely remember that. I mean, she's the person really to be talking to rather than Wise about retreating, because she should have a better sense of that than Wise and how often. But if you've got, I mean, Ken Doyle, I think, jumped off, and one of the things I wanted to say to him before he went is, nobody does watchful waiting anymore. We don't want anybody doing watchful waiting, at least if they're in the AnCan group. And so you've got to be following this. As soon as you go off, you still got to be doing all of your stuff that you were doing before, getting your PSAs, getting your scans, and staying on top of it. And, then you can start up again. And it isn't only 2 that you might be entitled to. You might be entitled to another 6 next time. So, I mean, that's the way that I see it. What about the rest of you in here?
I can't wait to hear what his doc says about that very question. I'm really interested to know in what she says about when to stop, why to stop, when to go back, whether to wait or not. I would love to know, and I'd love to know what it is about you, Chuck, that might have predicted in the first place that you would be such a great responder to Pluvicto. Did you have a certain mutation, or did you have a certain result on your PSMA scans to see if you were really positive, or was there anything about you that might make us think you would be a great responder?
Well, I think the fact that I pretty much had the cancer in the prostate and lymph nodes, and that's what showed up on the PSMA scan. Just it was glowing in those areas. So I was making PSMA. So I guess if I wasn't making any PSMA, I wouldn't be a good candidate.
Yeah. Any mutations or any genetic abnormalities?
No, I did have a with Rick's suggestion. I did have that repeated, and they didn't find any mutations. So
They didn't, because one of the things we know now that at least it wasn't in the public, I'm sure they knew, but it wasn't published, is that there are mutations that both make you more responsive to Pluvicto and make you less responsive to Pluvicto. So we know, for example, that if you're carrying PTEN, RB1, and TP53, any of those or some combination, you're less likely to respond. If you carry ATM, you're more likely to respond. So people with an ATM are really good candidates for Pluvicto. So and I wondered if he did repeat the somatic and nothing showed up. Hey, Chuck?
yes, that's right. Yeah.
Yeah. Okay. So, which is fine. I mean, and you have to keep repeating that, because what you make yourself changes all the time. It can change from
Yeah.
1 year to the next.
Right. Right. Okay. Okay. Thank you. I'll check with the radiation oncologist and see what she has to say about it.
Not the radiation oncologist, the nuclear medicine.
Oh.
The nuclear.
Okay.
You got to get the name right.
Okay.
Okay. I was
Nuclear
just
medicine. Okay.
yeah, nuclear medicine. That's what they're different people. They're different people to the radiation oncologists.
Okay.
Okay.
Active.
I was trying to remember her name. I'm just looking it up to see if I can find it. But anyway, it doesn't matter. France, maybe. I don't know.
We have
Jeff Wood. Sorry, go ahead.
No, I was just going to say I could find her. It shouldn't be a problem. But thank you.
I know Eric has his hand up. We'll come
Yeah.
back to Eric. But Jeff Wood, you had your hand up very quickly and it went down a while ago. Was there something on your mind that you wanted to raise? Are you there, Jeff Wood? He may have stepped away. We'll try him again. Eric, you have your hand up.
Yeah, so I was curious because I mentioned Pluvicto to Dr. Marshall to me, and she says that I'm nowhere near needing that drug. That's for more advanced cases, but it seemed like what Chuck was saying that his was in his prostate and a few lymph nodes, but it sounded like almost some similar scenario to me. So I was
Yeah.
curious. Yeah.
Well, it was
Eric,
a
as
little.
long as you're responsive to Lupron and Orgovyx, you don't need to think about Pluvicto. Maybe someday it's going to be used much earlier on in treatment,
Hmm.
but at the present time, you've got an effective treatment that you're responsive to and that has less serious side effects.
And
Am
the
I
other thing,
right?
Eric, is that Chuck started at a much further along the road than you did.
Okay.
So you had surgery and then it came back and and all the rest of it. But that poor old Chuck, he was de novo metastatic. They threw him in at the deep end head first.
Okay.
And then he did chemotherapy and other things. So the Pluvicto is one of those treatments that you can count on going forward that's going to help you. And we
Gotcha.
always tell people there's always other treatments. We're looking for new things all the time. So that's one of the things to make you feel good that you've got some treatments to use going forward.
Gotcha.
Right?
Yep.
Let's try Jeff Wood again. Are you there, Jeff Wood? Doesn't look like it. Doesn't look like it.
Chuck, it's really good to hear that Pluvicto is working so well for you, because we certainly know guys for whom it has not done anything.
Yeah, I'm very grateful. Very grateful. Thank you.
We have no more names.
Well, how about that?
Rick, were you looking for Peggy Chan or Anka Krantz or
I
Mona
think it was, yeah, I could have been Chan or Krantz, one of those two. It doesn't matter now, but thank you anyway.
All right.
Whoever it is, do you like her, Chuck? Do you like the do you like the nuclear medicine lady?
I really haven't really had a chance to see her too much. I saw her in the beginning, and when I got the treatments, I saw a different doctor a couple times. I really haven't really seen her too much, but
Okay.
yeah.
Okay.
I'm sure
Well,
I could.
between the two of them, between her and Wise, you should be fine in terms of getting good information. And if you're not, come back and we've got people we can talk to. We've got other people. I mean, I just saw that Dr. Koo is doing he's doing a session for PCF in a couple of weeks. So I'm going to put it in the reminder. But he did a wonderful webinar for us earlier this year, and he's a really nice guy, and we can talk to him about Philip Koo. We can talk to him about it, and he's made himself available to us. And we've got other nuclear med docs that we can go to. So you know, if we don't get a good answer you don't get a satisfactory answer. But one of the problems is I don't really think they know. I just don't think they know. They haven't done enough tests. Len or Ben or anyone else, I mean, are you aware of any repeat trials with Pluvicto that are going on right now? Retreating with Pluvicto? You're muted, Len.
No, and I was wondering if insurance might be an issue for retreatment. Was it an issue for
Al?
Latimer?
No, I don't think so. I think they're more willing to look at it now, but I'm not 100% sure. But also, we can work with, if it comes to it, we can work with Novartis as well.
You know, what I think is also kind of remarkable in Chuck's case is he's had previous chemo, right, Chuck? And I remember from the ASCO GU conference earlier this year, if you were treated with chemo and then followed with Pluvicto, the results weren't good, and vice versa also, because they say they're both DNA damaging agents, and therefore presumably they were taking out the same cells, the same sensitive cells. But it's wonderful that Chuck responded so well.
Well, one thing I do recall is that the people who had chemo before Pluvicto did better than the people who had chemo after Pluvicto.
Oh, you know what? I might be thinking of PARP inhibitor. Maybe it wasn't Pluvicto, it was PARP inhibitor. Sorry. Yeah, Ben, right? Okay.
All right. So I think back to you, Mr. Nathanson, to cut out. We got those MSs coming in a minute.
Take us across the line, Ben.
Thank you very much all for coming. We'll see you next week.
Thanks, Ben. Great job.
Have a great day, guys.
Good to have you back,
Bye,
Ben.
guys.
Good night.
Bye, everybody.